A little bit about type 1s. Call out one thing about a type 1. Okay. 3 or more segments. That's it. Lindsay said the other thing. No plane of motion fixes it. So that's good. So it's neutral. And it's, I'm sorry?
No major ones.
Yeah, you wouldn't do that with the neutrals. You wouldn't do that with the neutrals. But it's more than 3 segments, and it's found in neutral, inflection, and extension. Usually it's a result of a type 2 either below or above. And for that, I'd like for you to think of it this way. So, I know that looks crazy, but it's not too much. Whether something is, if it's rotated left, what are the 2 type 2s that are rotated left? Okay. What's going to end up happening if it's like, let's say, the middle of the spine? Okay. If it was an ERS left, if everything followed it, I'd be walking around like this. Okay. If I was an FRS left, I'd be walking around like this. Rotate inside bend to the left. I want to see straight and I want to see horizontal, parallel to the horizon. So what's my only option to compensate with a type 1 curve? In that situation above, so that I'm looking straight. Going to the right. It's going to cause right side bending and left rotation. So you're going to see it right, you're going to palpate it on the left. Now the opposite happens below the lesion. Okay. If I'm like this, ERS, I'm not going to side bend further away. I'm going to try to side bend under so that I'm at least staying supported. And that's what's occurring here. So for any lesion that's rotated left, the compensatory curve, or the neutral curve that's going to result of that type 2, above it's going to go away from it, and below it's going to come towards it, just to balance out the system. The opposite occurs here. If I'm extended right, or I'm flexed right, I can't walk around with this not knowing where I'm going for the rest of my life. So I need to do something like that, so I can look straight ahead. And that's why I'm going to side bend again, away from the lesion. That's the normal compensation for the curve above. Or below, if I'm here, I don't want to go more to the left, because I'll fall over. I got to get under it. And that's why the side bending comes as a result of that. Okay? So anything to the left, these are the resulting type 1 compensations. Anything to the right, these are the resulting type 1 compensations above and below. Alright? I wanted to at least make that clear to you guys as to how the type 2 can influence the rest of the spine. It of course depends on where the type 2 is as to how much of the spine is going to have to try to compensate for it. And remember, curves are adaptive or compensatory. That's why I try not to use that word compensatory so much. I quickly switch to type 1. An adaptive curve is something that's more present in an acute state. So if this just happened, and this is the resulting type 1 from it, and I treat this in the acute state, chances are, 98% chances are, that this is going to correct without treating it. That's adaptive, acute state. Chronic, compensatory, is a different situation. Been there for a year, 2 years. I have to work hard at correcting this. But this is also compensated for that same amount of time, which means tissue here has gotten shortened, tissue here is lengthened, tissue here is shortened, tissue here is lengthened. I'm going to have to correct this first, and I guarantee you I definitely have to now go and correct this, because it's so long-standing. Good. I'll just leave that on the board. Think about that and play with it. You know, become the segment of dysfunction, and then figure out what feels more supportive to your body from the ground up, and what also allows you to see parallel to the horizon from the top down. These are the things that as soon as they disrobe, you're seeing. And these are the things you want to use to help clue you in. Oh my God, I have an S-curve. Where's the transition of the curve? I've got to check for a type 2 there. I've got to look for one above it, below it, and dead in the middle of that. If I only had a C-curve, I got to look where that C-curve starts. I probably got a type 2. Or I got to look above it, compensating down. That's how you want to use this in your model. You haven't even gotten past A for asymmetries in your charts, and you almost already know what you have to treat. Now you're going to throw in your range of motion, mobilization techniques, check for your tissue abnormalities, and throw in some special tests to confirm it. But you already, after chief complaint in history, almost know what you have to do. That's based on that. All right, so let's go back to trying to now correct for that. And this is what we're dealing with here, right up there. It's a slight side bend right, rotated left. You'll see in the book that it's named easy normal left. Okay. And the reason for that is that it's named for the side of the convexity. It's just another way that the osteopaths do their terminology. Okay, so one of the things that is nice to do when you're treating type 1 is get good contact with your patient. And one way that I could also influence the control of the side bending component is actually... Keep coming. All right, that's good. I can ask her to drape her arm over the side here. Reason for that is that I can translate with now my third and fourth hands. So, contact here, contact with my belly. I can do the translation. Now I've got 2 hands to do whatever I want with, so I better do something with them, right? Okay, first thing when we treat a type 1, okay, after we get her in position, I'll get my leg back up there too. We want to find the most convex portion of the dysfunction. So I think, if I'm not mistaken, we have C1, C3, C2, and C3. Oh, T1, I keep seeing cervical, sorry. T, thank you. T1, T2, T3. Okay. So what I want to do is I want to place my thumb at the most convex portion, and that would be at T2. Okay. So I localize there. Place the arm over. Okay. Now what do I need to do? I need to try to get her to side bend left and rotate in which direction? Rotate right. Because it's a neutral dysfunction. Motions are opposite. So I make my contact here. I'm going to also do that swan neck grip up here on the side. So my right hand's going to rest on her head. Forearm's going to come along the zygomatic arch. I'm going to translate her right with my thigh. And if I translate right, I'm side bending which way? And now instead of jerking getting all the left side bending by bringing just her neck. By doing the translation from below, I have to put less stress through her neck till I localize at the segment, and I feel that with my thumb. Now what I need to do is I also now need to rotate her to that segment that I'm palpating. And there's my correction before I implement my muscle energy. So Meg, what I'd like for you to do is I'd like for you to try to side bend your head towards the right as you're also trying to rotate left. Good. Hold. Don't let me move you. 2, 3, 4, 5. Relax. I'm keeping her over her base of support, midline neutral. If I go into flexion or extension, I'm now going into type 2 mechanics and I'm going to mess everything up. So important to stay neutral. I further then side bend her and rotate her. And again, don't let me move you. Hold. 2, 3, 4, 5. Relax. 2, 3. Further localization and relocalize. Good. Come back up. Now again, I would definitely have to implement this if this was a chronic standing type 1. If I was fortunate enough, if it was just acute and I already treated the type 2, probably would have corrected. If it doesn't, this is the technique for the upper thoracic spine. Joanne?
If you're translating her
Right.
more to the right,
Yep.
why do you use your right leg? Why don't you use your left to push her?
Oh, because I'm just leaning this way and she's kind of falling against me going towards the right. I could push her. I'm kind of pulling her this way. That's all. Same thing.
Why don't you use your left leg on
You need
the
the
other
left shoulder
side?
to drop to get that side bend.
There you go.
Oh,
If
okay.
you push that left shoulder up as you go across your arm, you get a nice
Perfect.
translation.
I know you've been waiting all day to jump on that one, so it was a really good time. Thank God you guys are here today. Okay, so that's it. It makes it easier for the translation to go because the side bending has to go left. My leg is there, it's going to block the way. Very good. Kenya?
So now if we don't have a high-low table,
Can do it in a sitting position on a stool,
okay, and then, okay.
low mat table, wherever you need to. You could theoretically just do it without the position of the leg, and you would just have to control things a little bit more like this. You can even do the translation just by dancing with her.
Gotcha.
Okay?
Okay, thank you.
Yep. All right. Let's break and do that, and then